Welcome, everyone. Welcome to the webinar on Ontario Health Teams, Stories from the Field, Part 1. Today we'll have some excellent examples. Please join us and check in by going into the chat. And please, all panelists and attendees, click on that chat button and then say hello and where you're from and which OHT. Hello, Sarah from Kenora. Well, there are more people. There we go. More people out there because there's over 100 online already. Okay. Catherine from Central Ontario Health Teams. Julie from Guelph. Please make sure you're chatting to everyone. I think everybody is so far. Debbie from London. Odelia from Hastings, Prince Edward. Hello from Thamesville. Oh, and now they're coming fast and furious. I love it. Jim from West Perry Sound. All over this province, people are joining us today. Welcome to our event today, and we hope that you will be engaging all the way through. Welcome, Julie from Waterloo. Ian McKillop from Waterloo. There's an old face, old friend. Welcome, Ian, to check out what we're working on today. Chantel from Toronto. Olga from NOHT. I've gotten this wrong before. Niagara OHT, I think it is. And Garth, also from Niagara, Ontario Health Team. Welcome, everybody. Please continue to type into the chat and let us know who you are and where you're from. Today, I do want to acknowledge the land on which the University of Toronto operates. And, you know, for thousands of years, it has been the traditional land of the Huron-Wendat, Seneca, and Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island. We're grateful to have the opportunity to work on this land. And I invite you from your lands, where you are, if you wish to acknowledge where you are joining us from, feel free to type that into the chat as well, so that we might acknowledge that we are all speaking from lands that have been traditional territories for many, many years. One other thing to engage with us, we want to know about whether you've joined us for a webinar previously. We've been hosting these for some time now, but it continues to be the case that we often have individuals who are joining us for the first time. So please check into the box if you've joined us for one of these OHT webinars before. If you have, then please click yes. And if you haven't, then you can say, no, it's your first event. People are coming in, 90 people coming in, quite high response rates. Excellent. And I know a few people will be on possibly phones or things not to join, but we have over 100 so far. Well, thank you very much for joining us. And just to let everybody know, that 71% are here, yes, but we have over 30 people are joining us for a first event. So welcome, and you are in for a treat. Some others have come to really rely on us each month sharing, but definitely in for a treat this month. Okay, I'm really, really happy. Today we have an excellent lineup, and I'm looking forward to learning. So, Stories from the Field, Part 1. I'm going to host this. And my co-lead and co-conspirator, Ruth Hall, will be introducing the teams today when the time comes around, and you'll understand why. Ruth has been playing a particular close role with these two Ontario Health Teams that we are highlighting today. Some of our other speakers, Chris Archer is a project manager, professional, and strategic planner, in the digital health space. He's a skilled people manager with a proven record of collaborating projects across multiple sectors, which is really why he's had such an essential role within the Couchiching OHT. And he's leading the digital health strategy for the Couchiching Ontario Health Team. His colleague, Eric Buell, is an IT professional with several years of experience in multiple industries and joined the Couchiching Ontario Health Team in 2021 to provide the tech assistance and guidance. So we're really happy, and they're both going to talk to us about digital health in the Couchiching Ontario Health Team. We also have with us Colleen Neal, who's the executive lead for the All Nations Health Partners in Kenora, Ontario. And she's a strategic decision maker, innovative thinker, worked in primary care as the executive director of the Sunset Family Health Team, and has been working across multiple areas of government and levels in the city of Kenora for many, many years. Colleen has stepped into quite a unique role with the All Nations Health Partners, and will be sharing some of their work, particularly as it relates to mental health. But I think that the aspects of the work that they're doing will relate to many other areas of OHT focus. So today, I'm going to talk for a couple minutes, provide a little bit of an overview. And the way we got to know these two teams is through our developmental evaluation. So I'm going to spend a few minutes talking about that developmental evaluation, and then we'll get to the stories from the field, which is really why everybody's here. So I will try not to dally too long with this overview. A quick advertisement before we go. Just out, we're so pleased. Many of you have met Guy and Bodania previously on these events, talking about our understanding, and Gaia's really leading a lot of our qualitative work, and it's been a great benefit. So one of the first papers, based on the first round of interviews that we had undertaken with Ontario Health Teams, is available in Health Policy. It's just in press with a corrected proof now. It's not even officially out, but you can either Google that title or there's a DOI there on the bottom. And we'll be making this available. It's an open access paper, which means it'll be available to everybody. I'm going to start with this topic of developmental evaluation. First off, I'm just going to say, what is a developmental evaluation? Because people have heard of evaluations and they're like, oh, that's when I get tested. And that's not the purpose. The developmental evaluation is aimed to support innovation and development and to guide adaptation to emergent and dynamic realities in complex environments. So welcome to the OHT world. And we're very cognizant of that. It's sort of similar to an approach of R&D in a private sector product development. We're helping to prototype the OHTs. And it involves real-time feedback about what's emerging in a complex dynamic systems. And we bring that to the teams. And then we're also bringing it to share with you over the coming months. And this is the first introduction to the teams. And we'll be back with some of the more key findings in the new year. Where are we working? So these are deep dives. We're spending a fair bit of time with these teams, so we can't be everywhere. So there's 6 teams. We have from the North Rural Indigenous All Nations Health Partners, representing more of a suburban, urban, and rural area, East York region and North Durham. For rural, we have 2 teams, Chatham-Kent and the Couchiching Ontario Health Teams. We're working with 1 team in Toronto, the North York Toronto Health Partners, and we're also working with the Hamilton Health Team. How did we select these? Well, we considered a diversity of settings, obviously, focused populations, and other characteristics. We also looked at information from the original Organizing for Ontario Health Teams survey that we did, reports online. And what was really important is teams' willingness to participate, because it isn't without effort that these teams are involved with us. One of the first places we were co-involved was in identifying what are key questions, what will we be watching for? And that's having stakeholder input to develop those questions. So we came in with no a priori questions, except to say, how's it going? And the intent is really to come out with evaluation findings that are relevant, credible, and useful. So here are some of the questions that we asked the teams in the beginning. And I put these up because I actually think that these are good questions for all Ontario Health teams to ask yourselves on a regular basis, certainly on a periodic, like a reset, a strategic reset, or at the outset of your work. What does success look like for your OHT? What do you think it would look like? What are your strengths? And what do you anticipate some of the big challenges are going to be? And then from there, really to think about where you want to focus your learning and development. And that should really then lead to the focus on evaluation and how you do evaluation and where. You may not be able to do it in every aspect of your Ontario Health Team. So how do you pick those? And then how will you know you're making a difference? And then finally, with these teams, we have the extra question of how can the Health System Performance Network help you along your developmental journey? What type of data? And this is where you can see we're being fairly intrusive. We are attending meetings and recording field notes. We're observing the teams and taking notes during those meetings. From periodically, we're doing interviews with some of the people that have key roles or we're seeing may have unique information. We have some of the individuals in the teams are providing some journaling. They're responding to a few questions periodically. What's going well? How could things be improved? We're having access to many of the documents from the teams. And finally, we are implementing those surveys we've talked about with provider and patient experience as soon as the teams are ready. What do we do with all this information? Well, it's a co-designed piece, right? We have information coming out of the data collection. We've actually been working in integrated care for several years, and we are also learning about multiple teams. So we want to bring all of that information together in a shared interpretation. And we will be back with you to have a shared interpretation of some of these findings in the broader perspective of Ontario health teams across the province. What are some of the things that we're observing for? Now, you've been introduced, I think, previously to our context for capabilities for integrating care framework. And out of there, that drove and underlaid the original survey that we undertook and many of the original interviews. We think about what are the resources that the team has, what tangible assets and what are the intangible assets, the strengths of the team. How are teams thinking about governance and accountability? How are they organizing activities? How are things communicated? What type of communication across the different units of the team and more broadly, perhaps? Digital health was one other area and more. So we're watching for leadership, clinician engagement, patient-family involvement, vision and values, team climate and culture, partnering, care coordination, and performance measurement, amongst others. So a whole whack of interesting topics that we are watching for. And they really capture this whole framework that has basic structures, the people and values, and then the key processes, and that's underlying. At the same time, we are very cognizant of the building blocks for Ontario health teams. And the ministry has the 8 building blocks for the Ontario health team model. And so we're watching, how clearly is there a defined population? How are you working out the in-scope services and what's included? What about patient partnership and community engagement? How's that going? And we're going to be, so we're watching for all of these aspects, and we'll be coming back with stories that relate to each of the building blocks over time. Today, we have some stories around in-scope services, defining patient population, and the digital health building blocks. And they'll really be the focus, although there are other, nothing is uniquely, nicely packaged in a particular box. Everything tends to be very interconnected. So that's just a little bit of an overview of the way that we're interacting and what the basis is for some of the work that we have ongoing now and how we've been watching and paying attention to the teams, particularly the 2 that are here today. So I'm going to come back now to you and just think about some of those early questions that we had was we asked what the teams, what were their assets, what were their strengths. So first question to you is across these building blocks, maybe if you could identify the 1 or 2 strengths that you think for your Ontario health team or teams that you might be involved in. And so I will put this up now and launch the poll. So you can pick 1 or 2. There are options to select a few. So take a moment and just think about where your strengths are, where you think your team is doing a good job or has strong capabilities. Okay, I am going to end the poll now and share out the results so we can all have a look at broadly where are the strengths across the teams. And if you open it up a little bit sideways on your screen, you'll be able to see all the results at the same time. And so we see here that one of the greatest strengths is people have picked their populations and that they have leadership, accountability, and governance going into place. Many of the teams, 40% saying strength is around patient partnership and community engagement. And that is so essential, right, to having, our purpose in having Ontario health teams is to improve population health, patient experience, provider experience, and cost management, which really makes that patient partnership essential across the board. And finally, we have some in-scope services are the next in the list. So thanks everyone. And now we're gonna have the counter to this is going to be the areas for improvement. So I'm going to put up another poll here, and I'm going to ask you, where do you think you could be working to improve your OHT? So here's the same set of blocks, but what are the areas that you're interested in focusing your efforts and working on? Areas. So here's the results. Areas for improvement. So while it was an area of strength across many of the teams and patient experience, it's also an area, an opportunity for improvement, particularly the measurement and how well that's being supported over time. We're to see here performance measurement, quality improvement, continuous learning. That's an area. So part of today, and in fact, part of our existence is to help teams as much as possible advance in that area around quality improvement, continuous learning, and give you tips. And there are also other supports being offered through RISE, through Inspired, and some of the other ministry supported teams that are intended to help the teams with that area of quality improvement and continuous learning. So hopefully some of the tips you'll get today are going to help you in advancing that, and also just in having the discussion and the conversation with others. Here are the folks, just so you know, that are underlying a lot of the work, spending the time with the teams. Again, Gaia, Kaylee, Jen Gutberg, Elena, Ruth Hall, and myself. And so we'll all be participating and sharing out our findings with you based on our developmental. And so with that, I'm going to turn it over now to Ruth to introduce Couchiching and the Couchiching health team. Welcome, Ruth. I'm expecting Ruth is with us.
I'm always struggling with that mute.
There we go. Welcome.
Thank you, Walter, and thanks to everybody for coming today to listen to some stories from the field, getting down into the nitty-gritty. How are teams working to start implementing this new way of delivering care in the post-COVID era? I want to start by thanking Couchiching for agreeing to participate in the developmental evaluation. We are very privileged to be participating in your team. And Chris and Eric, thank you so much for agreeing to share your journey on the digital health path, building block. And it seems to be very much an area many OHTs are looking to improve. And I think your journey is going to be really insightful. You're going to give us about your experience in the challenges with enabling information sharing and sharing clinical tools across the providers for your priority population, which is the frail seniors, and as well as enabling virtual care appointments and check-ins. So I thank you both in advance for allowing us to hear your story. And I wanted to just also say that Couchiching was selected to be in the developmental evaluation because of its IT capacity and involvement in quality improvement. And although the clinical functional integration, which is about information sharing, clinical tools as well, was relatively low across all OHTs, Couchiching did rank quite highly. And also they have a key primary care champion that enables this to happen at the primary care sector. So thank you very much, Chris and Eric. Over to you.
Thank you very much, Ruth. And yeah, it has been quite a journey so far. And it's nice to talk a little bit about some of the things that are going well, and we're looking forward to doing that and some of the challenges, but it just seems like there's so much to do. So you sometimes get weighted down in that. So it's nice to take an opportunity to share some of the things we've been able to kind of move the needle forward with. And so again, my name is Chris. I'm a PMP primarily or whatever, but I am leading the digital health strategy. We hired Eric about 7 months ago to really do the heavy lifting around a lot of the background work we needed to do, and we needed to dig into our infrastructure to understand what we had, first of all, currently, and then how we would move to future states. So I want to do three things. We're going to take, I think, about 15 minutes to have a conversation, and always welcome for, chat and conversations afterwards, because we're not certainly get through everything today. But I wanted to do three things. We want to do a little bit of a short overview, talk to you a little bit about Couch and who we are, because we're a dynamic group. We're a small team, but all hands on deck. I want to kind of share our experiences with digital health. And really, for us, it's going to be the importance that we did in terms of taking a step back and really understanding our infrastructure to get ready for future state. Talk to you a little bit about Health Partner Gateway and some of the work that we're doing there, some of the frustrations with onboarding smaller organizations and some large checklists that need to happen. So some successes and some challenges there. And I think we should talk a little bit about the sharing of care plans through automation, kind of a unique project that we're underway with the eHealth Center of Excellence. So we'll share a little bit about that. And I think this is an opportunity in Forum to share some of the challenges we have certainly had around some of the funding envelopes. And we, like many others, have gone after many flashy, shiny objects. And need to pull back a little bit and really understand how these align to our priorities and move forward that way. So firstly, the Couchiching Ontario Health Team, just a quick overview. We are on the shores of Lake Couchiching. We have Oro Medonte, Severn, Ramera, and Aurelia is our collective four kind of townships in town of Aurelia that make up our Couchiching Ontario Health Team. We are cohort 1. We've been involved, so everybody in the Couchiching area from a very early stage. We invited everyone. We had all of our counselors from those townships. We had mayors, and we had people right across all sectors engage in a shared purpose way back in 2019. And for us, that was critical. Not only for the digital and wanting to communicate and collaborate together from that space, but just in general to kind of align to some of our guiding principles. So we have 7 anchor partners. We have 2 private organizations, which offers great opportunities and has throughout the pandemic. And then we have other hospital, the CFIT, we're the signatory. We have Helping Hands, a community services agency. We have a nurse practitioner-led clinic. And then we have Care Partners and ProResp. All have been at the table since day one. And what I will say is that there is a strong history of collaboration in the Couchiching area. We're pretty small and nimble, but the digital health implementation and the implementation of the OHT mandate has been challenging. And I don't want to go into this with anyone thinking that we've been able to cruise through this, because we're a work in progress, just like everybody else. So if you go to the next slide, please, Walter. I wanted to share just this to give a little bit of a context of how we're structured. And I will say that this is evolving. It continues to evolve. We had our developmental evaluation feedback yesterday, and based on some of that, some of this will change, and it should. We don't have it perfect by any stretch of the imagination, but I just want to orient you to some of the work. The collaboration table sits in the middle. So that's the group of all the community partners, township counselors that meet on a monthly basis. And their kind of information exchanges from the right and the left side from our working groups. And you can see them all there, as well as our JET, which is our joint executive team. That's where our anchor partners are. Our PFAC, I want to talk specifically about them and meaningful engagement. Primary Care Physician Council has just got underway. And then obviously a community practice in terms of feeding that information back to the collaboration table. So I share that only because there is a level of complexity, even at the stage we're at. I talk about us being cohort 1, but we literally, all of these working groups, some of them formed out of the pandemic, as well as the work being done with PFAC. I mean, really, it's been a pandemic response. And so we, in June of this year, recognized that we needed to relook at our work, certainly from a digital health space and collaboration and sharing of care plans, and just recently had a retreat in September. So we're evolving, and yet some of the work moved forward. And I'm going to share some of the work that we've been able to accomplish, and some of the important features to share and perhaps discuss today. Next slide, please. So again, really our objectives remain the same. Even though we've done a reset, we wanted to understand our current capabilities. We wanted to do an inventory of current systems. We've done that, assessing digital resource capacity, interviews with OHT partner organizations to identify needs and gaps. So that has been part of our process. Aligning with the OHT vision, digital strategy aligned with year one projects. We still call them year one projects, even though we're well along the chronological timeline. Expand access to existing solutions while planning for the future. This is where we're going to talk a little bit about Health Partner Gateway and some of the work that had been done in the past, and then utilizing that for partners and some of the challenges there. Embedding digital resources. This is, I'll just give you a little sneak peek into what we're going to be talking about, and Eric's going to be chatting about, is the eHealth Center of Excellence. So really what this is, the sharing of care plans through automation. As most will be familiar with HPG, it's one thing for your organization to be onboarded. It's much more difficult for others to onboard, in terms of, if with smaller IT departments, our two partners, Helping Hands and Nurse Practitioner-Led Clinic, you know, the human resource person is also doing digital, and in some cases also the CEO. And so there's challenges there. And so I'll share about some of the solutions that we've moved towards with the eHealth Center of Excellence to support us there. The other piece of that, again, a snapshot into what we're going to talk about, is around, you know, with HPG, you have to, you know, kind of log in and go look at the care plan. And our primary care group was very clear that, yes, very helpful to be able to view the care plans. But if we've got to go out of our own EMR and then into, you know, Connecting Ontario and view it that way, it's not efficient, and it's not likely that it's something they would use. So that's why, again, we've partnered with eHealth Center of Excellence, because they have this robotic process that allows you to embed it into your EMR, and then it is updated in the EMR. And if other people access HPG through Connecting Ontario or other partners with home and community care, it gets updated in through this AI process in the evening. So you have one document of proof, of truth, I should say. So we'll talk a little bit about that. And then the developing digital governance, we're working, you know, we're back working at that. We've got all our anchor partners now lined up as part of our digital group. And again, the work continues to evolve. Next slide, please. Certainly not going to get into all of this. I just wanted to kind of take our work plan and put it up in some type of visual document so we could understand it and to share with you today. And if you look at the far left-hand side, now we're going to get into the heart of the discussion, talking about our CFIT infrastructure, the work that needed to happen there. We're going to talk a little bit about, again, on the left-hand side, Health Partner Gateway onboarding and eHealth Center of Excellence. So let's move to the next slide and get into a deeper conversation around some of the work that's being done and some of the challenges. So I'm going to turn it over to Eric at this point and talk a little bit about the importance of our decision as a JET to really look at our infrastructure and some of the work and stresses and successes that have happened over the last 7 months, because Eric really has taken this on full go. And while the pandemic had slowed us down, we wanted to make sure some of this work was being done. So Eric, looking forward to hearing your update on infrastructure changes with our OHT.
Yeah, thanks, Chris. So as Chris mentioned, we've had a number of almost moving goalposts with different priorities. And one of the biggest things when I came on, we're in a rural community, and there is a lack of IT resources in our area. So what we've really been trying to work on is building out, almost making ourselves as like a model organization that others could follow, and trying to increase collaboration. So one of the very first things that we had to do was review all of our internal processes with the OHT, whether that would be through purchasing with standardizing vendors, looking at hardware, and making sure that all of our staff had the tools that they needed to do their jobs. New security platforms, remote support tools, particularly with people working from home during the pandemic. that was one of the big challenges. A lot of the stuff that was put in was a reaction to that, and wasn't implemented in the best way, just because it was something that had to be done as quickly as possible. So we tried to take a step back and build out more stable platforms, and really getting our own house in order. And where we've noticed this has a lot of crossover, particularly with primary care, a lot of the practices that we work with day to day haven't had somebody that they could go to kind of do the same things that we've been doing. So we've really tried to build out a new process and a new IT support structure, and our own team here that can provide the necessary insight for those organizations, particularly with things like the Health Partner Gateway onboarding through the Health Center of Excellence. A lot of the organizations have had a lot of difficulty with filling out surveys, knowing what they have in-house, and that's something that the Health Center of Excellence has helped with. And now our next push forward is really making sure that we're all aligned strategically, getting everything up to a modern standard, and just making sure that going forward, we're ready for some of the funding envelopes that are being pushed through by the ministry, because that's something that we found that we need to get the baseline and build a foundation first. And that's really what we've been working towards.
Very good. Thank you for that. Angelica, I noticed you're with the Guelph OHT, and you two are engaged with the Health Center of Excellence. And so what I will say is the challenge for Guelph and ourselves currently is that with the new privacy officer in Ontario, they're looking at some of the automation projects. And so we're sitting on hold. We have a primary care group that's engaged. We have created over 300 new care plans for our defined population. And we are anxious to get this going. So, we are in the process of writing a letter and request to hopefully move this forward. We have investment there. And so I will just leave that as perhaps one of our sore points at this point with that process. And then my next point on the slide here is really, I want to talk about access to CRIS. And I'm looking for feedback in the chat. We looked at the heart of our team is really around the care planning process and coordination of care across our providers. So much like other centers, and everyone's doing it slightly different, or OHTs. And so we started to look at again through the pandemic, and so it's been on again, off again, is around access to CRIS. And really, our team, when they're developing the care plans, really need access to what care provision they currently have, and they don't have it. So we initially looked at, what would this look like? Could we get our own instance of CRIS? And maybe in the chat box, if anyone has had success, I know that there's a few OHTs that have dug into this. Way back when we attended a seminar that had some people. I'd be interested to see an update on that if they happen to be on the line. So that was more of a question for us, and it really is critical. That access to CRIS for all we're doing, our clinical care redesign, yeah, so are you using CRIS? That's a question Walter set out. So yeah, just be interesting to see who's he's utilizing, the CRIS from home community care. And so the next part I wanted to kind of share, and I don't want to take up too much time because if we have a chance for discussion, that would be great, but is really the digital funding envelopes and the process, that has been part of that. For us, as I showed the complexity of our governance structure, is, even this waterfall of information that's come our way, and some of they're great opportunities, and we're excited about many of them, and most of them, to be honest with you. And so, in the early days, we reached out and assembled a couple of people together to kind of get a skeleton in, and proposal in, and kind of re-engage after the fact. And then it wasn't really engagement. So I would say that for our team, again, we're a fairly small team, but I'm sure this is shared across other teams. And I have heard it on other OHT, discussion groups, is you never knew what was coming next. And so, do you invest all your energy in the initial one? And we jumped right on the remote patient monitoring. And we've been successful in that regard, and we're quite happy with that. And unfortunately, we're in a situation, and just sharing some of our challenges and our gaps here is that, so we had several iterations. We first, it was in June when it was supposed to be and on time and in its fulsome form. It was chiseled down, and we went back and forth several times. We just recently, this month, been kind of awarded that funding, but we're in a tough situation now. We're a small community. Attracting resources, is not an easy thing to do. And we have, a five-month turnaround time to get, all of our legal documentation and we're working with UHN and using the Medley program. There's a lot of work to be done. So we said yes with lots of question marks, but we want to try and move this forward. My ask, and certainly our ask, is from a ministry standpoint, is there an opportunity to share some of this funding, to show sustainment funding ongoing for us to do this work? A tremendous amount of time has been put into this. So that's around process. And then the meaningful engagement piece, again, back to our process, to engage primary care, even though we have a super rock star primary care leader, engaging with them, they meet monthly, is not an easy thing to do. And we are trying to, but the process is so quick. Meaningful engagement hasn't happened. And even with RPM, some of it's we're going back now to share with our specialists, the work we want to do with CHF. Not complaining. It's wonderful to have the funding, but there are obstacles that are very difficult and challenging. And I think it's important to share in this kind of forum. The last thing is just touching around strategic alignment. Is, we applied for some things that are on the table, and some we haven't been successful with, that really aren't aligned to what we're trying to do with a mandate. You could make it fit, but in terms of really driving, indicators forward in this year, what do we want to, accomplish this year? So we've, again, taken a step back and just trying to make sure that anything that we're engaging in really aligns, and we have the capacity internally. And obviously the health human resources is a much larger discussion to have as well. So thank you for kind of listening to some of our thoughts around who we are, what we look like from a governance standpoint, and then some of our challenges and successes and gaps. So I'll go to the next slide, Walter, and certainly open it up to questions, comments. I'm hoping this forum is just a chance to chat. So.
Yes, indeed, and I think we would very much welcome everyone to be joining in the chat. And some of the chat is coming in now. Some people sharing experiences related to the I think that's OH funding, and so I've put out there another follow up. What have people been applying to out of those digital health? What kinds of programs? Also, what types of information and platforms are people using in terms of getting around access or privacy capabilities? So I think, I just, some chat, and I'd be interested in hearing about whether people can consider Chris to be an EMR, EHR, or more of a repository type. And now we're getting some ideas in. Some of the teams, and this is, Sarah Bevanek from South Georgian Bay, talking about home care community providers, coordinators having access to the EMR, and now also thinking about how could they connect the EMR with Chris information, because that's where they're putting their information, right? So maybe if it could just somehow feed, I don't know if anybody's been able to connect Chris, or if that's a technological or a privacy constraint, where the constraint is there. But I think a few people, because I also saw another one earlier about that access, providing access from, it was earlier anyway, so one of the comments came in around that. The other question I'd have actually to you, well, I guess actually both Eric and Chris, would be, it came from Patricia Maurice early on. And it was around engagement. You had up there your Patient Family Advisory Council, and how is that group involved across your OHT generally, but actually what maybe specifically in this area of digital health. I mean, this is all about patient information and patient's own health information. So I have an interest in understanding how that might be, how they might be playing a role.
That's a great question, and it's something that we are working on. As we came back from our retreat, one of our priorities is our PFAC and how to meaningfully engage them across our working groups. So our process so far has been each of our working group leads engage with, and now there's only four individuals, two more are coming on board. What I will say is another individual who is our chair has been engaged right from our visioning and our shared purpose. So we have had continuity, but we are working on that kind of engagement across our working groups. So to share just quickly is what we've decided to do is each of our leads meet with the PFAC to share the work that they're up to, how they might be engaged. And we quite transparently as a JET are learning what co-design means. I think we have in our mind an idea of what it is supposed to be, you know, when we read it on a piece of paper. And I think our PFAC members have been very clear to say, you know, they have their ideas and we're working through this. This has not been easy for us. But we have, again, we've had the 3 members for quite some time. So we have got feedback around the digital health strategy, but we need to do it in a more meaningful way. So I hope that helps, is to share that we're working through this, and it is a work in progress and a priority for us. That and our primary care group, that again, we've got that super leader that shares with, we have 2 FOs. We have a family health organization in Aurelia, and Couch is basically half and half, makes up about 48 physicians. So, you know, conversations are there, but to answer your PFAC question, we're a work in progress with that.
Right, thanks. And I see some people are writing in now with some of the ways that they are. This is exactly the conversation we're looking to engender. Ocean being a platform used in Waterloo, Wellington. I hope I get the acronyms right today, we'll see. That's supporting instant messaging and communication integrated with primary care EMRs. So that's next phase, trying to integrate that into CRIS so that it can be a platform. I know that there's another platform in Mississauga used, I think, called Care Connect or something like that, and they're trying to use that as a messaging system or a communication tool. I think it's Guelph Wellington, no, Guelph, working to connect the CRIS with the Sharon bot as well. I think that's the one that you had that has that kind of AI information in the EMRs being used. So great to see that these, you know, I think by sharing learning across the Ontario Health teams, because everybody is facing the same challenges and people are approaching it in slightly different ways, and sharing that learning is probably the best we can do right now. So thanks for bringing in the conversation, and I see some of the suggestions coming up, and let's continue to share these, right? And, you know, hopefully not stymied too much by privacy or privacy, as you may say it. I wonder, you know, you alluded to pausing a little bit, Chris, related to some work that the Provincial Privacy Office is doing. Do you know much about where that's headed, or?
Well, here's what would be extremely helpful. As we, with the Guelph OHT and perhaps 1 or 2 others, are writing letters, I would love, I'm just sending my my email through. If you have an interest at all about learning about this, or this is maybe a possibility, and you'd also have to give us permission, our team's permission, to share that as part of our letter of support. I think that would be helpful. I think this is the way to go, especially knowing our primary care group is on board with this and the efficiencies and the plan for us with coordinated care planning long term. So if people don't mind doing that, you do have to give me permission to attach that. But I think that would be helpful if I could ask that of the group today.
And I've prompted also a little spot in the chat relating to the patient family engagement strategy, because I think the Provincial Council has had some views on having, patients having their data. So that's another aspect, is patients access to data, but also patients may have opinions on the capabilities of their providers to share that information. And sometimes the government's responsive to what the people want.
Yeah, I think that's a great question, Walter. Now, specifically with our group, it would just be the coordinated care plan, which they sign off on, and there's consent and all that kind of stuff in terms of access to that information. So it's not the full EMR, but it's a great question.
Yeah, Ruth, jump in.
Can I pivot a little bit to a different question? Knowing that we're talking about evaluation, Chris, and about the virtual care, that seems to be up and running, ready. Are you thinking of getting feedback from your patients and providers on their experience with the virtual care?
We actually have. We actually created this was way back, I think, to Sarah Grace, when she was doing some work with us around kind of a patient engagement survey and understanding from that. So we have actually taken that information to try and identify and have better decision making around also provider experience, right? So we do have that, and we're utilizing that information as we build our virtual and digital strategy moving forward.
Yeah, great point, great question, Ruth. Thanks.
Great question.
So I'm going to move us along to Colleen now, and we're going to hear a little bit about All Nations Health Partners in Ontario. It's going to be a little bit of a shifting gears, but their work in advancing mental health. And Ruth is also going to give us a little bit of an intro to the team. I think I'm meant to be sharing screen. It's not clear that I am, but Ruth, if you could start off with the introduction, and I'll make sure I get the slides up.
Sure. Thanks, Walter. And it's my pleasure to introduce the All Nation Health Partners, OHT. And Colleen is going to be speaking to that. She's the executive director. And why we selected All Nations Health Partner was that we believe the findings obtained from other OHTs might not apply to this unique case. All Nations is an Indigenous and non-health sector organization-led OHT, which is not typical. And mental health and addictions was their priority population for many OHTs. So we felt that the learnings from this OHT would benefit many, because mental health and addictions usually involves multiple providers. How do you get everybody at the table? Thinking about how the best way to integrate care, think about it from a population health management perspective. So that's, I want to thank Colleen and everyone else at All Nations. I have to say, I want to take a moment to pause and say, I love attending the meetings because they start with an elder giving a prayer. And it just sort of sets the tone, and everybody gets ready and really sits, ready to engage in the conversation. So that's one thing that's really struck in my mind. I want to thank you for your bravery, Colleen, to share your story as your OHT has worked together and been engaging for several months in an exercise to re-envision the mental health system in the All Nations Health Partner OHT. Over to you. Thanks, Colleen.
Thanks, Ruth. Thanks, everybody. It's nice to meet everybody. Most of you I've met and watching people come in. I just want to recognize too that there's people from this team on the line. Sarah Diaz, especially, I saw her name pop up, who is actually the co-chair of our mental health working group. So I just want to call her out. And one of the other unique things about our health partners within our working groups too is that we try to have an Indigenous and non-Indigenous co-lead for all of our working groups as we move forward. So we really are overarching that engagement, and it's beyond just and we'll talk about how that came to be, but we really are working hand in hand. We have multiple layers not only just sort of health partners across, but we have provincial, we have interprovincial, and we have provincial federal boundaries that we're trying to work with. So next slide, Walter, please, if you don't mind. So the All Nations Health Partners has actually been working together before we became an OHTs, which is a little unique as well. In 2015, there was a presentation made to our local council, city council, because we were in such a huge health crisis and a health deficit, both from a health human resource. We should be sitting somewhere around 29 physicians in our community, and we are currently sitting at 17, and with some actually on the forefront of retiring and hanging on just to keep us going. And with that, and again, like I said, the multiple systems that we work within was really a call to action to come together to do this. And in 2019, we were part of cohort 1. We came together not only through the granting of the province becoming an OHT, but we also came together in ceremony through an Indigenous ceremony as well. So that's important, and I'll speak to that as we move forward and what that means to us. Next slide. So we do have here, this is our partners. Like Bruce said, we do have most of our health partners, but we also have strong engagement from our district services board, our municipalities, our unorganized townships, and service providers, and both of our sort of political organizations as well to move this forward. And I think that has to do strong to do with our level of commitment and engagement and how we move forward and how we expect people to lean into this work. Next slide. This is our, as you saw Couchichings. We all had to do this. We know this is our governance structure. This is our collaborative decision-making model. So for the All Nations Health Partners, again, our logo came to us through ceremony in work with our elders. If you want to know more about that, you can see that on our website. So even our colors, how we do things, and again, how we move is based on this model and our Indigenous leadership. So you'll see that we have, I believe, 11 working groups and 3 advisories. So the advisories that you see are in color. So we've changed our primary care and specialist advisory to be a clinical advisory, our traditional healers advisory, and our patient family elder advisory that oversee the work that we do. And then our core partners sit at that partner table. Okay, thanks, Walter. Just to give you a rough idea, we're in Kenora. If you don't know where Kenora is, we sort of are that last municipality before you hit the Manitoba border. A lot of our tertiary center and tertiary care and specialist care goes into Manitoba, into Winnipeg. So we are 2.5 hours to Winnipeg. We're 5.5 hours to Thunder Bay, which is our closest Ontario center. So just to give you an example of where we are on the map. And we are on beautiful Lake of the Woods, and we have 10 First Nations communities that are part of our All Nations Health Partners, along with Kenora, Sioux Narrows, Nestor Falls to the south, and the unorganized townships that surround us in that area as well. Thanks. So I was asked today to speak on our mental health and addictions working group. Not unlike most communities, we have mental health issues that are going on. We have Kenora was a site of 2 local residential schools. To the north of us was an Indian hospital. We have a opioid crisis going on in our community, there's no question. And we also have high homelessness, and we have a housing crisis. And not only for those that are in need do we have a housing crisis, we have a housing crisis. So even when we try to attract healthcare professionals to our community, we actually lose people, good people, because we can't house them here. So it's a complicated mix of how we, and that is why we have both our health providers on our partnerships, but we also have our municipal and political leads on there as well, because we're not going to get through this without them. Okay. So just to speak more about our mental health and addictions working group, again, we came together as a number of, you can flip the slide there, Walter, came together for need to look at the mental health and addiction services delivery. It is old, it is antiquated, it is siloed, it is fractioned, and it is complex. So I'll say that. And I'm also here to say that we do not have this all figured out. This isn't one of those cases where I'm like, here's how it is, here's how you can figure it all out. But this is a little story about our journey anyway. So next slide, please. All of our working groups have a terms of reference. Our terms of reference is framed in the same terms of reference we use within our collaborative decision-making model. We try to establish those to have our work plan, our priorities and our deliverables and our milestones. It feels like every working group right now, Chris and I were talking about this when we started, is that there is a race to the finish for some reason. I don't know if that's because we know we only have funding for 1 year, but the engagement piece and some of the deliverables sometimes feel rushed. And it has to, I think, again, we're coming out of a pandemic where we were rushing all the time and trying to fill holes and get things done. And sometimes it feels like that's the overarching, it just seems a little rushed and stressed. But with that, we try and go back to the 7 sacred teachings are something that we have embedded, like I said, not only in our overall governance, but certainly within all of our working groups, and remind people how we came together, that we did come together in ceremony, and that these things, we call these out and call these to action at the start of all of our work together. Again, to establish our intentions and identify our goals and objectives. So even getting that together and getting everybody in a room together on a call together was hard. I always laugh. It was like we had people that, have been working in mental health and addictions for 30 years with lots of great learning, but also wanted to know from us, why are OHTs different? They've been through the LINs, they've been through regional collaborations. They wanted to know where those tables now went and how this all fits together. So there was a lot of conversation about, why is this different? What are we doing that's different in the past? And I always laugh because I used to talk about, we were on Zoom calls. Those were the tops of the heads where people would sit on their cameras with, heads down asking questions. And then we had our new and our millennials that were in the frames as well, in their Zoom frames, looking at us with, multitasking and doing all those things and trying to figure out where they fit into this overall picture as well. So we had a lot of groundwork that we had to do about, again, really getting those goals, objectives, intentions right, and right from the beginning, and what it was we were trying to do. So I quickly realized as we gathered those inputs and insights, not only from our service providers that are living in this, but we must have those with lived experience working with us as well. Similar to other OHTs, we did not have our patient family, and we call it patient family and elder advisory, up and running. That group was getting mobilized as well at the same time. So again, we didn't want good work to stop while those other work was going on. So we just made sure that we embedded people with lived experience into the work that we were doing, and talked about our assumptions about the system and see if we could come to some kind of goal or objective that we could all work on. We did start working on the bigger picture of what the ideal system was. As soon as we started talking about sort of one, single door, one single point of entry, when all of those things, you could still see people backing up and rolling eyes and those types of things, because again, we had multiple systems from an IT and digital strategy perspective. We had multiple service delivery users using multiple things and couldn't see past what they were being asked by their funders and how we could change at a local level when it was so prescriptive from their ministry and their funding obligations. And how were we ever going to come together and make those changes when we didn't have a locus of control beyond that? So we did bring someone in from the outside to sort of start having those conversations with us, to have a fresh approach. And we just really asked everybody is to let those assumptions and those things that get in the way sit aside for now, that we know we need to do those things. And we know we're going to need to come up with those strategies to do that. But let's sort of look at the art of the possible and what is meaningful for our patients, and stop sort of protecting our own silos and doing this. This wasn't easy work. And it was interesting because along came a funding opportunity right in the middle of this. And it was a very good test. It became very real. And it was also about taking services to people rather than sitting behind your desks. And it was great to see providers come together as a small test of what we could do and how we could be impactful when we worked together. And then we were able to leverage that. And now we're on that next piece of what bigger project can we work that's meaningful for our community. And we have to start using that language, what's meaningful for our community. What are those long standing issues that have got in the way of us doing good work? Next slide. So this is just sort of what I was speaking about. The other thing that Kenora is and is not is we are often or have in the past been set up as a regional site to service communities that are 3, 4, or 5 hours away from us. And again, because they use like a per capita formula for things that we do. And that doesn't work for us because of our geography. So one of the things is our detox center was actually set up to be regional, but it would mean sending somebody from Sioux Lookout, 4 hours away to a detox center in the middle of the night kind of thing. So again, stop pretending what we are and what we aren't. But again, really working with our funders, and we do have our funders now coming to some of our meetings to understand why things and help us see our way through to how those things get in the way. So that's what we're up against. That's what we're working on. Jennifer Drever from Kenora Chiefs Advisory and Sarah Diaz are the co-chairs of our mental health and addictions working group. And again, we're looking at starting to work together as partners to solve problems in our community, rather than just trying to look at those scary things like amalgamation in one door and conversations that have been historically got in the way and stopped us from working together. So that's where we're at with that group. If there's any questions?
Thanks, Colleen, for that very honest conversation about the time it does take to bring so many provider organizations to the table and drop their organizational walls and think about this patient being at the center of the work that needs to get done.
Yeah, and I know that's not unique. We all use that language about, patient-centered care and patient-focused and all of those things. So, I mean, earlier in the conversation, just having patients in the room and people with lived experience, whether they're, people say, well, they won't understand, some of this administrative behind the scenes stuff. And that's true. But having people with lived experience in the room keeps people, back to our 7 sacred teachings, keeps people honest, keeps people respectful, and the humility is grounded in the room as well. And for us, knowing that those organizations have signed on as a commitment and have been part of that ceremony keeps them engaged in the room about moving that work forward. So I know it's, like I said, I would just encourage people, don't worry about getting it right and perfect and drafted and on paper and all those things. Just have people come. If someone's interested in coming and sitting in the room, just have them come and sit and keep those expectations simple. It does change the conversation.
There's a question from Ali Griffey around having the municipality, and I'll put this, I'll just put it in the chat for others too, but for you in the Kenora area, and you have, I think, a history of municipal government too. So is it helpful to have them at the table, and in what ways?
Yes. So a couple of ways, actually, because they're not in the health service business. But it keeps people out of their silos where people would do deputations to council about, doctor shortages and issues at the hospital. And they always want to go to, people know this, they always want to go to city council and blame or hold council accountable to these things. And in the past, we've seen people say, well, that's not our mission, mandate, purpose. Having them part of this conversation and a signatory to this group has them lean in. And again, not just push off, but has, again, more engaged in the solution. And so where can they help? Well, we've had city councils help us hold mortgages for medical clinics and those types of things. And, in property situations where we can leverage property for different kinds of housing, in zoning issues where we want to have hostels, or we have a zoning issue that's getting in the way of good work. The municipality leans in and becomes part of that project team because they are a member of the OHT. So there are things, it's not always just those health systems pieces, but where we're looking at as social determinants of health and how we're going to move these things forward, housing and homelessness and our vulnerable sector as part of our mental health year one, which was our year one. We couldn't do this without the municipality. Even our policing, standing down on our tent cities and moving people before we have strategies in place to move people off the street and things like that into better situations. Without those non-health partners involved in understanding the bigger picture and strategy, we're not going to get anywhere.
Yeah, that's excellent. And I think Mike Hindmarsh actually had a question specifically saying, the engagement process is a bit unique in all nations. And I don't know if you want to speak to that a little bit. And there was one other question that I think was also interesting challenge. And I think for sure a challenge that you've had is in the space of having existing service delivery needing to change. And the using existing resources in new ways is very challenging. Maybe talk about some of those challenges, what you hear, and then also maybe if there's anything about your process that helps with that, and what your process is.
Yeah, so it's interesting in dealing with leadership at the table, the partner table, and having that sort of we're all equal and sitting that, and then you go to work with a working group, and the working group says, well, if the hospital would just do this, and you have that partner. So the unique role in having those conversations, and I've gone to leaderships of other, I could quietly go to and say, hey, so what's it going to take to get you to move on this, or what's it going to take to get you to move on that? And it's amazing the answers you get back, because sometimes they're not as big as you think they are. And then we can start having those conversations. So sometimes it's, you need those big in the room conversations. And again, I go back to our 7 sacred teachings about honesty and truth, respect and humility, and calling those out sometimes, because sometimes you'll get the packed answer or and they say, I just really need you to be humble right now and help me with this. And we call each other out on those things. The other thing we've done too is having, like what Chris was using, that collective voice is really important. So whether having our municipal mayors and councils, when they're going off to their municipal conferences and speaking to ministers and ministry, and knowing what's going on at the All Nations Health Partners, and knowing that they're a member of an OHT and speaking to those things, we have these multiple branches of conversations and we can bring them back together. And so it's really important. It is really important. Policing is another one. They're not a member of our partner table. However, they are an intricate member of many of our working groups and some of the work that's going on as well. So, sorry, I don't know if I answered your question.
Well, I think you've talked about some of the processes, right? And I think actually that honesty is really fantastic. Sorry.
Yeah.
There's another question here, and I think that I often wonder about this, and we've had questions even around the design of our patient experience survey, around engaging with people with lived experience. And there are so many people that are OHTs are putting their arms around. So you may have patients and families engaged in counsel or otherwise, but did you reach out, or how did you do that for this mental health work? Did you ensure that there are people with lived experience involved, and in what ways is it possible?
Yeah, it's interesting too, like the being in small communities, and I'm sure other people in rural communities experience this as well, is when you do a call out, someone will say, well, how about Walter? We should get Walter to sit on that. And I'm like, yeah, we've been hearing from Walter for 30 years because he's the token person that comes to sit when there's a call out for these types of things. And we really have been trying to use our partners to say, is there anybody you think would be really good, but just would need a little nudge to be part of this and explain what it means and what we'd be looking for, so it's not scary and intimidating and all those things, and get some voices. So our youth wellness hub was a great advocate to have people come through with those lived experiences, people on the street. We have a community outreach program, that say, these are some people with some really untapped leadership ability that could help with that. We do have people that are working in the system that wear dual hats. And so their insight is very useful as well. So it really, we did do the basic, on social media, in the paper, those kinds of call outs, but we find in this community that you'll get the same people over and over, or the same people are already sitting on the hospital, patient family, working group, on those types of things. Those personal invitations from people they know and trust, whether as a service provider or well, they could come from anywhere really, that these people have a good story to tell and deserve, time and have, to be invested in kind of thing and listen to. So that's where we went, is those kind of some personal invitations and quietly asking, not just the broad invite, but personal invitations.
Thank you very much. Ruth, from your perspective and having observed the team in action, I know that any other thoughts or questions for Colleen, comments that are coming up?
Well, I think it's important to recognize the amount of time this OHT takes to really engage, and it's a big initiative to engage, and it should not be underestimated. And it's what this OHT has prioritized and is seen to be important across all the working groups and at the partners table, which has really struck our team in observing the All Nations. And I think highlighting your work, the work that's being done in All Nations, really, I think resonates with many, is that there are so many players in the mental health field. How can you possibly pull this together in a few months?
It was nice to, yeah.
Long-standing silos of money that make it very challenging. So I kudos to all the work you and your working group, Sarah and Jennifer, are doing, and Daphne prior to Jennifer, to really, really take the time and do thoughtful engagement. And it's expected in your region, but why isn't it expected everywhere else?
Yeah, I think the other thing too is though, and Chris alluded this, and we were talking about it before we started today, and I know this is probably everybody that's working with OHTs on the call, is that these tight timelines, like this is huge. This is a huge amount of undertaking to do, and I know everybody knows this, but it's if you're going to get it right, and if it's going to be sustainable, we appreciate everything that's coming at us all the time. But to speak from an All Nations Health Partners, the reason we got into this partnership in the first place is because we were in such a crisis of deficit. And now we're doing more, even more in that deficit. And then along came COVID. So I don't know that we're going to find efficiencies in the system. I think we use the word innovative. in different ways and effectiveness, because the efficiency piece that ship sailed for us a long time ago, because we've been doing so much with so little. We know we have to work together. We have to. There's no other way through this. So that's why we came together even prior to the OHT pieces. I think we recognize that. So we know that these are all good things. It's all the right things to do. But the pressure of time and the pressure on the people doing the work, because it's not new people doing the work. It's people doing more work. So, and again, I've heard that across all avenues with everybody. And I'm so thankful for our partners that continue to lead in. And I hear people say, I'm ready to give up. Is it worth it, right? Are we doing the right thing? Like all of those things. And I just keep saying, yes, it'll be worth it.
Yeah, thank you. Thank you very much. And Mike has just indicated the North needing a different paradigm for transformation. And I think that's true. And even across the North, there won't be necessarily one paradigm for all. So to have that adaptive nature. And I really appreciate your raising the point of time. One of the things is we've looked globally around the world at integrated care initiatives and instances of population health management, as no one did it in 2 or 3 years. They've all been progressing over time, and even before things start to look mature, it's easily 8-9 years. So it's a matter of having the courage to step forward, even though one has a sense that it's going to take time.
Mm-hmm. Thank you.
And I see in the chat the 7 sacred teachings really being appreciated. And I think 2 things, one, appreciating the 7 sacred teachings, appreciating the 7 generations approach to thinking about decision making. And also, I think that really having and for our perspective as researchers and evaluators coming back to data and digital health is some things around OCAP principles. Really, there are much that we learn from the Indigenous perspectives and traditions that are very helpful universally. And it's not actually special treatment for Indigenous populations. In fact, I think they're very much lessons that we all need to learn from. Yeah, go.
Yeah, the OCAP principles is something that we lean heavily on through our digital strategy as well too. And again, I would encourage, if anybody hasn't taken the OCAP training, it's quick. I think it's only like 4 units, but it is very thought-provoking, and not just for Indigenous people, but for patients, because it's that slippery slope of where things went very quickly and where they went wrong. And where we don't want to go again. So there's some great lessons learned in there for everyone as we navigate these things with the privacy commissioner and things like that as well. So if anyone hasn't had the opportunity to take that training, I would encourage them to do so. Certainly in our calls for, in our Truth and Reconciliation for health.
Yeah, thanks very much. Again, any closing comments from either of you before we move on? I think it's been quite enlightening and very honest. Both today. Chris and Eric, appreciate your honesty as well. And I know that even in the chat, there have been some of the patients and families knowing that even in that conversation, that it's a work in progress still, and that honesty is appreciated. There was a question in the chat just for people as they're transitioning about OHTs abandoning the term patient actually though, and moving to person, and how does that work? Language, it can be important sometimes, often, in fact. And I know that even in how people term the patient family engagement within the work. Joyce asked what the training was again. That's OCAP. I can't remember exactly what OCAP stands for, but it was OCAP training. And if you look it up, you'll be able to find it.
Yeah, Algonquin College has a nice program that they do, and it's ownership, control, possession, access. You got me on there, yeah. But yeah, yeah.
Oh, and there, Tracy's got a link up for everybody, so that's very helpful, Tracy. Thanks for sharing. I've definitely seen quite a bit of sharing today across this event. I really appreciate everybody joining in. And so here we go up to share, just to close out here a little bit. This was our first event for Stories from the Field, and just gonna make sure I'm on the right Sometimes my screens don't match up properly. And this was a real opportunity. So thank you, Chris. Thank you, Eric. And thank you, Colleen. Thanks, Ruth, for hosting these. Next month, we'll be back again with more stories from the field, part 2. I like to think of these as live talks by real OHTs. And some of our topics that will be covered next month include governance, patient-family engagement, and strategic planning, amongst others. And we'll be highlighting a few other OHTs with their learnings and what they've been able to advance over time. And again, we'll have different members of our evaluation team introducing these groups and what we've been seeing out in the field, so to speak. I want to just thank everybody one last time for joining us. We're all involved. We will have this event up online within a week. You can check out all of our Ontario Health Team information. There was a question in the chat. We were a little bit behind on our website, but information is available. If you have questions, do contact us by email, oht.evaluation@UToronto. And we do post pieces around on Twitter from time to time when we have new events. You'll see a link for that paper coming up through Twitter soon. And I just appreciate everybody in the audience today being part of this event. Thank you all. Have a great afternoon.